Hello, my name is Konstantinos Papadopoulos. I'm cardiologist in Thessaloniki, Greece, in European Inter-Balkan Medical Center. And in the next 20 minutes, we're going to talk about 3D echocardiography and how to acquire images and orient ourselves into the space. These are my disclosures. So this is how the first machines in 1986 of 3D echocardiography looked like. You can see how big there were. And this is how we appreciated the first biplane views of long axis and short axis view. You can understand that the quality was not very good, but the images have evolved over these years. It is very important that the probes also have a reduction in size, and the concept is now to have one probe for everything, for 2D and 3D cardiography, and not to change the probes during our examination. For the new cardiologist that wants to input the 3D cardiography in his routine practice, we have to tell them a few things. First of all, it's very important to know how to acquire the best images in 2D echocardiography, meaning transthoracic and transesophageal as well. We have to know how to optimize our image settings before 4D acquisition. We have to understand and know the different data sets of 3D echocardiography, full volume, 3D zoom, live acquisition, and single bit and multi-bit acquisition. We have to recognize the triangle of interdependency, the relationship between spatial and temporal resolution, and the volume size. And we will see what's the meaning of that in the next slides. We have to use standard 4D transthoracic and transesophageal protocols, understand the differences between transthoracic and transesophageal echo, learn how to optimize our images, how to crop, how to orient, and how to do offline analysis, and of course enrich our knowledge with 4D echo hands-on courses. The concept of 3D is to move away from the surface and go into volume, as you can see these images. And it's very important to have a nice ECG gating because we want to stitch volumes from different cardiac cycles. The difference, the main difference between transesophageal and transthoracic echo is that the distance from the valves, from the mitral valve to the esophagus is very little, and it's closer to acquire the mitral valve from the esophagus than from the chest. And that's the main difference, and that's why we use transesophageal echo for obtaining nice 4D images of the mitral valve. About the triangle of interdependency, this triangle is a relationship between the spatial resolution, the temporal resolution, and the 3D volume size. What do we mean about these relations? We mean that when we increase the volume size, the image that we obtain, at the same time we decrease the temporal resolution, which is the frame rate of the patient, and the spatial resolution, which is the quality of the structure that we want to obtain. So if we reduce the temporal resolution, at the same time we increase the spatial resolution. So there is a direct relationship between these three parameters. The basic form of 3D echocardiography, we have to remember, it is the biplane views, views that have 90 degrees difference between them, and this is the first form of 3D echocardiography, because we can at the same time appreciate structures like here, for example, we take the views from the central part of the mitral valve, and at the 90 degrees we can appreciate the A2, P2 scallop, and we can do the same thing for these color 3D images. We have also triplane views where we have 60 degrees of difference between these views, and this is very important in when we want to appreciate wall motion abnormalities in ischemic heart disease, where we can at the same time have a 4-chamber, a 2-chamber, and a 3-chamber view. we have to know about the levels of 3D imaging. We have to know that we have the axial level, the azimuthal, and the elevation. And when we have a 3D image, we can call this volume rendering image, like in this view where you can see the volume rendering of this mitral valve. And at the same time, we can appreciate the azimuth level, which is the view that we obtain from our 2D image, and the elevation level, which is in fact the depth of the image that we obtain at the azimuth level. It is the image at 90 degrees from the first one. Someone that performs 3D echocardiography has to know about all the 3D data sets. He has to know about full volume, single bit or multi-bit. He has to know about live 3D scanning, which is used in interventions. And he has to know about 3D zoom, either multi-bit or single bit, which is used in demonstrating certain cardiac structures. We have to know how to navigate into the space and what to expect to see. For example, here you can see a mitral valve with prolapse of the posterior leaflet. And when I change my view, I can at the same time appreciate the left antral appendage, which is at the deep side of this image. We can see the anterior leaflet, the aortic valve, again, the unfast view of the mitral valve. It's very important to know the structures that and to know the anatomy of the structure that we want to demonstrate. That way, we can navigate and we can have the best of the image that we want to visualize. There are some applications semi-automated that after inputting some markers, we can have with just the press of one button, 4-chamber, 2-chamber or 3-chamber view. And from transthoracic echo, we can also visualize the septum or the valves, the atrioventricular valves of this patient just with pressing one button. In order to obtain a nice examination, 4D examination, we have to be aware of the restrictions of 4D echocardiography. We have to know about the artifacts, the dropout artifact, the stitching artifacts, gain artifacts. We have to know that it's important to have ECG gating, and the patient needs to breath hold. We don't want atrial fibrillation or arrhythmias in order to acquire multi-bit acquisition. Because we have stitching artifacts, we have to overcome the low frame rate issue, especially when we need to appreciate the wall motion abnormalities. And of course, we have to remember that we don't proceed to 4D echocardiography if our 2D images are not perfect. Here you can see the same mitral valve with prolapse of P2 scallop towards lateral. In the center, we have our image with the best, with optimization of the gains of this image. And in our left image, you can see that this view is undergained, and that's why we can see that we have a lot of dropout artifacts. And in our right image, you can see that we have something like smoke, which means that our image is overgained. So it's better, remember always, to acquire an overgained view, because in offline analysis, you can reduce the gains. But if you acquire an undergained view, then you cannot put gains in the offline analysis. We can enhance our images with flexi-light or TrueView. It's the same application with different names for GE and Philips. And for example, in this Barlow disease of mitral valve, with flexi-light, we can appreciate the prolapsed scallops, and of course the P2 flail scallop of this mitral valve better than we can appreciate with normal 4D views. When we evaluate the 4D color, we have to navigate ourselves into the space. We have to For example, in this mitral valve, we have to demonstrate the anterior and posterior leaflet, have a view that looks familiar to us, like from 2D images, and then optimize the color gains and change the baseline of the color map, as you can see here, and have our color image that looks best and can help us understand the severity of this mitral regurgitation. What about stitching artifacts? Stitching artifacts come from acquiring multi-bit acquisition, because you can see these lines between the stitching of the cardiac cycles, and in order to avoid that, we need to tell the patient to hold his breath efficiently. We don't want atrial fibrillation, and we don't want other arrhythmias, and of course we have to save our image after we have obtained the final view. Dropout artifacts are the inability of 4D echocardiography to visualize a thin structure, like we have the fossa ovalis here, or the aortic valve. You have to remember that the aortic valve is parallel to the beam, to the echo beam. So it is so very often we have dropout artifacts, and looks like we have perforation of the aortic cusps, but this is not true. Sometimes, if our images are undergained, we can have this kind of artifacts even in mitral valve, like here. As you can see, we have perforation, but it's not a true perforation because there is no color in color Doppler from this spot. We have to know when to depend on our images. For example, in this patient, we know in advance that we cannot rely on these 4D images to be accurate in ejection fraction and volumes, of course, in wall motion abnormalities. And it's very important to know the limits of our images. And sometimes, no matter how hard we try to obtain a nice 4D view of mitral valve, we have this final result, which is very suboptimal, and we cannot use these images. So always remember that if you don't have a nice 2D imaging, do not proceed to 3D imaging, because it will not help you anyway. The low frame rate issue is something very important when we need to see movement. For example, in this metallic mitral valve, where we can appreciate the opening of the discs. Here we have, in this left view, we have 20 frames per second, and in this right view, we have 4 frames per second, and we are not sure about the movement of the discs, and this would be a huge problem if we had to appreciate this mitral valve with this occluded disc, where you can see that we have a very nice imaging, because here we have 42 frames per second, and we can be accurate in telling that we have one disc occluded in this patient. Of course, this frame rate issue is very important when we appreciate wall motion abnormalities. These views are from the same patient, and you can understand only by the right view that we have an apical aneurysm, and we have wall motion abnormalities and a low ejection fraction in this patient. Information that cannot be obtained from this left view. In 2021 or 2020, the indications of 3D cardiography are accurate estimation of volumes and ejection fraction of chambers, evaluation of valvulopathies, congenital heart diseases, and of course, transcatheter interventions. About left ventricle, it is important to obtain always in full volume the whole structure that we want to evaluate. Here you can see that we have the whole left ventricle inside, and it is important to understand what we see in our volume rendering images. Here, for example, we can appreciate the mitral valve, the aortic valve at 12 o'clock, and we have here the tricuspid valve. And of course, with this image, we can measure the ejection fraction and the volumes of this left ventricle. And there are publications, of course, and recommendations from EACVI and American Association about the normal values of volumes and ejection fraction for 4D echocardiography. And you have to know that 3D echocardiography correlates better with CMR than 2D echocardiography, and this is an established knowledge. We can prefer triplane ejection fraction by rather than biplane Simpson's method, because with triplane we can insert also the posterior wall and the anterior septum, and we can be more accurate in the ejection fraction. But of course, we have the foreshortening of the apex issue that that we can overcome with Auto LVQ. This is a dedicated application that we can align our views, and we don't care if we have foreshortening of the apex of the left ventricle. So always remember, whatever vendor you use, either Philips, Siemens, or General Electric, when we want to measure the ejection fraction and the volume of the left ventricle, just include your left ventricle inside your views, and then you can align the images and avoid foreshortening and have a very accurate ejection fraction and volumes. We can use multi-slice views in order to appreciate the wall motion abnormalities from the base towards the apex. And of course, we can appreciate very well the right ventricle with dedicated software that gives us one image that and have information about volumes, ejection fraction, contracting, TAPSE, and all that just with one image acquisition, which helps us gain a lot of time in our daily practice. About valves, we have to be honest when we say that the first indication for 3D echocardiography was the acquisition of MITRAL valve, the evaluation of MITRAL valve. As you all know, it's a very complex valve with asymmetric leaflets and this subvalvular apparatus with chordae and papillary muscles. And in order to understand what we see in mitral valve, we have to acquire the so-called surgeon's view. And in order to achieve that, we have to place the aortic valve at 12 o'clock. And that way we have here the anterior leaflet, here the posterior leaflet, and we have at the left side the left antral appendage and the lateral side of the valve with A1, P1 scallop. And at the right side, we have the medial part with A3 and P3 scallop, and we can acquire images like that, where we can appreciate at the same time both leaflets with scallops and the subvalvular apparatus with chordae and papillary muscles. If we obtain this image, it is very easy afterwards to understand what scallop is prolapsing. For example, here we have an A2 scallop prolapsed with a ruptured chordae, and here we have just prolapse of A2 scallop and the billowing of the posterior leaflet. And here you can see different cases of prolapse of the posterior leaflet. Here a P2 prolapse towards lateral, here a large P2 prolapse, and here we have a P2 P3 prolapse with a ruptured chordae of the posterior leaflet. We can also use flexi-light or TrueView in order to enhance our imaging, in order to visualize a coaptation defect at the coaptation line. Here, this is an example of functional mitral regurgitation. You can clearly see the coaptation defect, which is in fact the vena contracta area, if you want to call it like that. And of course, we can create the model of the valve, even if it is functional MR or degenerative MR. Here we have a functional with tethering of the leaflets towards the apex of the left ventricle. And here we have a prolapse P2 scallop of this posterior leaflet. And with this dedicated software, we can have data for the annulus and the leaflets as well. For, this case is it's a case where you can see also the coaptation defect between the anterior and the posterior leaflet, and we can appreciate the vena contracta area with flexi-slice or multi-slice views, and we know that vena contracta area in functional mitral regurgitation is hemielliptic and not spherical, and this is very important because in European guidelines, severe functional MR is when we have ERO more than 20 millimeters square, but we know that PISA is spherical and not hemielliptic. And when we include the vena contracta area concept in our patients, then we can see that MR severity upgrades always by 1 grade in functional MR, but we have a nice correlation between ROA and vena contracta area in primary MR. In mitral stenosis cases also, we can appreciate better the mitral valve area because we can go to the tips of the leaflets, and we avoid overestimation of the mitral valve area. And of course, we have the estimation of other valves as well, like tricuspid valve. Here you can see that we have a coaptation defect between the leaflets of the tricuspid valve, and on this right image we can appreciate very well the 3 leaflets of the tricuspid valve. In order to orient ourselves and be good in estimation, we have to place the septum at the right side. So here we have the septal leaflet. On top you can see the aortic valve. So opposite to the aortic valve we have a small posterior leaflet, and next to the aortic valve we have a large anterior leaflet. You always remember that as right cavities and tricuspid valve are just behind the sternum, it is better to obtain our images for tricuspid valve from transthoracic echo and not from transesophageal echocardiography. We can also have information about the tricuspid annulus, and this is very important for interventionists and cardiac surgeons where we want to implant an annulus ring. About aortic valve, it is not only nice images of this valve. We can appreciate the valve by obtaining this quality of images, and we can use it in TAVI cases when the patient, for example, has a renal insufficiency and cannot take a contrast agent for CT scan. Then we can have a transesophageal echo. We can align our views and take the 3D annulus area and perimeter. And we know from publications that this correlates very well with CT scan, and we can give information about the TAVI valve that is going to be implanted. We can also give information about the coronary ostia, about the right and the left coronary ostia, and know if we have any problems after implantation of TAVI valves. In transcatheter interventions, for example, we can clearly measure an atrial septal defect and measure the rims better, or the minimum and the maximum diameter. We can obtain images of live guidance. Here you can see the occlusion of left atrial appendage and the relation with a metallic mitral valve. Here you can see a PFO occlusion where we have the occluder attached to the guide catheter. And of course, in mitral clip implantation, we have several steps that we use the 3D echocardiography, but mainly when we want to see the perpendicularity of the clip with the arms open to the coaptation line. So in all transcatheter interventions, it's very important to acquire 3D images in order to finalize our implantation of the device. So concluding, we can see that echocardiography is expanding fast following the advances in cardiology, and cardiac imaging with all novel techniques is indispensable for better diagnosis, high accuracy of what we say to the cardiac surgeons or the interventionists. And of course, for the echocardiography is necessary for the management of these patients, for guiding structural procedures about valves and all other defects that we want to occlude. Thank you for your attention, and I would like to say that I was honored for this invitation by the committee, the organizing committee of these great seminars, education seminars. Thank you again.